it's now applicable to COVID as of adding 2 slides last night.
Same thing.
Yeah, like Abdullah, I wrote this 2 months ago. I just wanted to say to everybody out there, what a terrible week. What a hard job. I'm honored to be side by side with you guys. Let's stick together. Let's protect ourselves, okay? All right, so like I said, this was written 2 months ago, so man, does it seem tone deaf. But I'll do my best. I added a few slides quickly. Let's just take ourselves to pre-COVID land for a second, okay? And entertain other things. We used to pride ourselves on our differential diagnosis. Remember that? Okay. All right. So I'm going to be talking about Pulmonary Sonography. It's a quiet morning in CCT. Unannounced, EMS busts into the bay with this guy. So he's 50 years old, no known past medical history. He called, or somebody called EMS for shortness of breath. He's presenting respiratory distress, unable to give a story, secondary to his work of breathing. EMS gave some albuterol nebs as they do and put him on CPAP. No clear improvement in breathing. So a vague exam to go with the vague story. He's 150/90, 120 beats per minute. You can see it. He's a little tacky. He's pretty hypoxic to be on full blast CPAP. He's breathing at 40. It's 98 degrees. Not that that really means anything. So not good vitals. Mildly obese. He's in distress. Capable of 2 words. Can't breathe. We've all heard that before. Decreased breath sounds bilaterally. You don't know what you're really hearing. He's breathing so fast. There's so much noise from the CPAP and all the commotion. You don't really get a good lung exam here. That's happened to all of us. You can say there's no stridor, just for the purposes of this question. Tachycardic, regular, no murmurs. Maybe a little bit of lower extremity edema, just to make sure our differentials brought. So the patient is in extremis and we know so little what to do. Here's my update. Yeah, this is clearly COVID. PPE, please. So I'm going to be talking about pulmonary sonography. This is one of the great things I've taken away from this residency. Really amazing physicians in our emergency department doing all sorts of things with ultrasound that people like my dad have never heard of in their lives and probably never will. So we're back in the recess bay with that 50-year-old. So what is he? He's undifferentiated dyspnea presenting in extremis. So what were the first steps I wrote a couple months ago? IVO2 monitor, call respiratory, grab the ultrasound, prepare to intubate. Added that last night. So this is Pulmonary Sonography lecture, so we got to take the hard stuff right off the, or we have to do an echo first, just to make it a tidy lecture. All right, so no pericardial effusion, normal right ventricle, unable to determine squeeze because the guy's moving around a lot and he's got poor windows. The poor windows, by the way, makes me think of COPD. All right, this was supposed to be an interactive thing, but we don't have that. Well, we've got enough people here. So so let's see. You've got that patient, right? Their vital signs could really mean anything. Their exam could mean anything. They can't give you a story. The only 2 words they can mutter are can't breathe. This is your pulmonary ultrasound in that context. Abdullah, what do you think?
I'm seeing A-line.
Yeah,
A-lines. Sliding of the pleura.
Yep, good. He's seeing A-lines and he's seeing lung sliding. So A-line dominant, normal lung sliding. What are we thinking? Okay, maybe asthma, COPD, maybe not a primary lung issue. Maybe he just took 2 bottles of aspirin. Yeah, go searching. in this context, though, especially with the full clinical picture of this guy, and he was also tripoding in that picture. I start the combinevs, mag sulfate, everything, looking at giving IM epinephrine. It sounds like the guy completely deserves IM epinephrine at this moment. Moving on to ketamine to try to avoid intubation is what a lot of people practice. Same patient, new ultrasound. All right, that was not, the last one was not actually what you saw. This is what you saw. Robbie, what do you think?
I'm not sure where you are on the patient.
Yeah, I'm right here.
Left upper problem.
Yeah.
Yeah, you might be seeing.
I'm not in the liver.
What's that?
I'm not in the liver.
Not liver. I mean, you can't really see the spines, or you want to increase the depth to see the pleural effusion, so you can't really see that. You see like a little bit off angled. Maybe there's some A lines, maybe there's a couple E lines scattered, but.
What do you think of this portion over the right side?
I think it looks like a little.
It's
not a little form.
Patatization. Thank you. So, so that's a consolidation. Also, that just kind of immobile, big chunk of something with it looks heterogeneous, could be a mass, possibly. In this context, you're looking at giving them early antibiotics. You know, I've actually never seen hepatization of the lung, I don't think, or maybe once, but really it's just focal B lines is the most common finding. C line shred sign being the thickening of the pleura, really like a kind of discontinuity of the pleura. And then a small effusion, you can see that might be your only finding, a small effusion with a few B lines would tip you off to a pneumonia. Here we go, this is a classic. Did you guys miss this? Or actually, this just means something else nowadays, it is. What do you think? Volunteer? What are we seeing? Those shooting all the way down to the bottom of the screen.
Multiple B lines.
Yeah, B lines all over the
B
place.
line all over.
Let's say this is bilateral, pre-COVID. What is this?
Fluid overload.
Thank you. Abdullah said fluid overload. What else we got? ARDS, absolutely. Okay. So diffuse B lines, and that was bilateral. You only saw one image. So yeah, pulmonary edema, ARDS, bilateral multilobar pneumonia. Pre-COVID, best course of action, BiPAP in this undifferentiated patient, plus minus nitro and alprazolam, Lasix. These are the things that we're looking at. Next, same patient. Next finding.
No, you are in the
Where are we putting the
Sorry. This is kind of low. This is on the kind of the bottom of the right one there. That is the liver. That actually is the liver. Sorry guys, throwing you off. Yeah, there we go. There we go. What's that big all that anechoic stuff? Pleural effusion. All right. So this patient, very tachycardic, very hypoxic on CPAP, becoming very hypoxic on CPAP, with a large pleural effusion. So differential malignancy, possibly infectious, yes. Fluid overload, ascites, hemothorax. That could have been a hemothorax. Did you look at his back? He might have got stabbed. He didn't tell you anything anyway. So that's what we're looking at for him. So if he's desatting with a large effusion, I think we should consider a pigtail to improve his oxygen requirement. Next, same patient. What do we see? Yeah, no lung sliding. Think about pneumothorax, of course. It's going to be that until proven otherwise. He's already desatting. I don't think you want to wait around for the chest x-ray. Also, large consolidations, mass, can prevent some lung sliding. Also, something else found in pneumothoraces will be lung point, which is essentially you have lung sliding, and then you move you move a rib down, and then you no longer have this lung sliding. That tells you exactly where it's separating from the pleura, the lungs.
Much more specific for pneumothorax if you can actually talk about
Much more specific, as Dr. Willis added. So needle decompression and chest tube. Don't wait around to see if this is 20% of the lung. He's already desatting. There you go. Added this last night.
Those look like C lines and B lines.
B lines, thick pleura. What's this guy got?
I don't know, what does that go
Yesterday.
like?
I took all the hearts, or a lot of those questions off the table with the vague echo before, just showing
He got COVID.
COVID.
He'll prove another one.
Yeah, he's got isolate. Something that went out on the group chat from Ben Wiseman yesterday. Something that we know how to we now know how to deal with these COVID patients somewhat, but a request from the internal medicine team would be to send like a whole battery of tests, including ProCal, CRP. These are things that we want to keep in mind because medicine is adding these onto every single patient apparently, as well as serum ferritin is another one they mentioned in addition to your basic labs. Yeah. So I asked. This is a couple months ago, of course. I asked my dad what he does. He's never used an ultrasound in his life. He's never used an ultrasound to even place a central line. He doesn't know how to turn the machine on. I asked him what he does with this patient because he's seen this patient about 10,000 times in the last 40 years. He says his approach, he immediately gets his portable chest x-ray in the room. He fancies himself pretty good at getting information out of that. And he gets a trial of albuterol, stays with the patient in the room. If he still has no clarity at all after those two things, he nasally intubates them. He gets a CTA of the chest. Not a lot of people doing that. Yeah, it's the way. All right, that's all I got.
Wonderful.
I would say, I mean, it's not that long ago. When I started residency, ultrasound has completely changed, I think, the way we can manage these patients. In residency, it was a patient comes up like this undifferentiated, maybe has a history of CHF and COPD. You gave them everything. You start albuterol, steroids. You gave them 80 milligrams of Lasix even before everyone was using nitro and an aliphalat, and then you're just like, all right, something worked. I don't know what worked. You put them on BiPAP. This is in my short stint of working some shifts in the community, ultrasound is really, really helpful. You can identify kind of what route you want to go and potentially not give medications or therapies that are not going to help maybe make the patient worse. So it's real quick and easy. A lines, B lines, look at the heart, and then you kind of know where you have to go. And it can maybe help you decide to intubate earlier or not. Especially if you're in a situation where you can't sit and watch the patient. Now, if you're going to do an ultrasound, I've done a couple for COVID, you really got to be careful cleaning them. So I've been using pro covers for any time.
Absolutely.
Even if you're not sure they have COVID, like everyone presuming has COVID, you have to do a full wipe down. You can't. This isn't a time to be lazy about it because you're gonna, if you infect someone because you didn't do a good job cleaning it, like you could kill someone. So be careful.
Absolutely. Willis, I don't know if everybody out there heard that, but Willis was saying that when he was training, essentially it was throw everything at him, treat them for obstructive pathology, treat them for fluid overload, and then see, maybe something will work. And ultrasound has really been a game changer there. Robbie added that we really need to be protecting our machines, our ultrasound machines. The ultrasound department has requested that we always use probe covers in any question COVID, which is just everybody these days.
And that's not just for ultrasound, but for like placing IVs, because every patient who needs an IV placed is also a COVID risk. There's fomites everywhere, and we have to keep everything clean.
Absolutely vigilant. Thanks. Oh, Derek.
This is like more anecdotal, but I've been ultrasounding a lot of these, and as literature has already kind of stated even before the days of COVID, is that you can catch pneumonias much earlier than you would on a chest X-ray. Regardless, pneumonia is still a clinical diagnosis, but the one thing that I haven't seen is that most of your B lines that you're getting are in the posterior lung fields. So if you get them to sit up and really take a look at that, I've been getting like clean chest X-rays in patients that look and smell like COVID, and you get the B lines in the back.
Absolutely. Derek said he believes that ultrasound might be more sensitive for the early COVID findings. I certainly had a case just like that last week. Totally normal chest X-ray, B lines on ultrasound, clear COVID story. So yeah, the utility of it is enormous for risk stratification. If they've already got some B lines, then you got to if you're going to discharge them, if they look so good that you're going to discharge them, then definitely strict return precautions. I really like what Dr. Center sent out as well, walking the patients around, seeing if they desat, because them sitting in a bed and us getting a little 30-second snapshot of them at 93% or 95%, they might just totally, I think it was Dr. Center that sent that out. Was it you?
Yeah.
Okay. But us getting like a little snapshot of a pulse ox sometimes doesn't do. Sometimes they'll get down to 80% walking around, and that's probably not the person you want to cut loose.
Another thing to remember with these patients, and Dr. Kilpatrick is going to give us, he's putting together a nice Sauna COVID lecture specifically for COVID, but looking at the B lines in these patients, the B lines are not getting more dense as you move down towards the inferior lung fields. They're actually having the same density throughout, whereas someone who has like pulmonary edema, it's dependent, those types of things, the B lines become more dense and more concentrated as you move down the lung field. And I think Kilpatrick also had sent out an email saying, it would be great to get a 12-field lung sono on every single one of these patients, because that could really help us make decisions. But if it's like quick and dirty, like Derek was saying, the posterior lung fields seem to be the easiest to see on. And you can also see the C lines as well for the like patchy pneumonia.
I just want to highlight something Derek said too, just that this is true of all pneumonia, that ultrasound is more specific, and it usually predecesses the chest X-ray in terms of findings. So it is a good way to identify that clinical pneumonia. You can see it on ultrasound before it shows up in the X-ray.
And if you don't have them, then I think you feel more comfortable about sending them home.
Right.
I mean, for me, that was the important part. Is we see a lot of people with fevers and coughs who say they're short of breath, and if you don't have B lines and you walk the patient, they don't desaturate, that should make you feel very comfortable about discharging the patients, which we definitely should be doing.
Dr. Willis was emphasizing part of Derek's point that the ultrasound findings can precede the chest X-ray findings, can be more sensitive in pneumonia, not just COVID. And then Dr. Center added that this is helpful in risk stratification.
Awesome. All right, and overnight, folks, please go home. And then let's just take a 5-minute break before we get started with our next section.